Hello, my name is Ehrin Armstrong. I'm an interventional cardiologist at Adventist Health St. Helena. And today I'll be sharing some cases of using intravascular lithotripsy for treating patients with critical limb ischemia. This case is a 67-year-old man with a non-healing wound of the left fourth and fifth digits. The patient had had angioplasty of the proximal posterior tibial and peroneal arteries in 2020. He had known inframalleolar disease with occlusion of the plantar artery. The patient's wound had initially healed but then stagnated over the course of a few months. And given that he had had proximal intervention but had known inframalleolar disease, he was referred for potential intervention to the plantar artery. This is the baseline angiogram in this patient's case. You can see that the posterior tibial had minimal disease in its proximal course, but then further down at the level of the ankle, there's occlusion of the plantar artery. You can appreciate here that the occlusion starts here and reconstitutes after only about 20 to 30 millimeters. And you can see the ongoing plantar based on collateralization. And on this non-subtracted image, you can appreciate that there's clearly very severe calcium with railroad tracking of calcium across the entire distal posterior tibial and actually all the way down into the plantar branches themselves, such that this almost looks like a stented region of the vessel. In this case, I was able to advance a support catheter as well as a Fielder XT wire into the site of the lesion. I was able to loop the Fielder XT wire and pass it down into the plantar branch. I then performed a hand injection of contrast to ensure that I was in the true lumen of the ongoing plantar vessel. And I then advanced an IVL balloon measuring 2.5 by 40 millimeters at 4 atmospheres. I chose the 2.5 millimeter balloon because this looked like the vessel visually was approximately 2 to 2.5 millimeters in diameter, and I wanted to ensure good vessel wall apposition while delivering IVL. I chose to perform 120 cycles here in order to get a full 2 minutes of angioplasty combined with intravascular lithotripsy to optimize the standalone result of this vessel segment. Because the bailout options here are very, very limited, this is not an area where you'd want to put in a stent. And this is the final angiographic result. You can see here really outstanding results throughout the plantar branch with essentially no residual stenosis and no dissection either. Outstanding flow to the level of the heel as well as the ongoing plantar branches. And actually, pretty dramatically, this patient's wound healed within the next 3 weeks, despite it having been there for months and with a prior intervention more proximally. So I think this case really speaks to the importance of treating directly all the way to the level of the occlusion and to get straight line flow to the wound, and the fact that it is possible to perform intravascular lithotripsy in these more distal vessel segments.